Thank you very much, sir. On the behalf of Department of Transfusion Medicine, I'll welcome everybody for the CGR over here. Today, the department will be sharing its experience in the form of therapeutic apheresis, which includes both plasma exchanges as well as cytapheresis. The word apheresis basically means that to remove, and we have been using this technology for collecting various components from healthy blood donors, as well as this can be used as a therapeutic modalities. In conditions like myasthenia gravis or a patient of acute liver failure awaiting for a liver transplant, the use of therapeutic apheresis has definitely improved the outcome of those disorders. Today here, my resident Dr. Pallavi and Dr. Kirti will be presenting our experience in past 4 years, and by the means of 5 cases, how this modality has changed the outcome and help in better patient management in various clinical conditions.
Thank you, sir. Good morning to all. On behalf of Department of Transfusion Medicine, we would like to present our experience with therapeutic apheresis. Coming to a general overview, we will be starting with a brief introduction, discussing the various types of apheresis modalities available, discussing on how to plan an apheresis procedure, then our 5-year experience and 5 clinical cases. So coming to a brief introduction, therapeutic apheresis is an essential part of modern transfusion medicine. Decision is based on American Society for Apheresis guidelines, that is abbreviated as ASFA, or evidence-based or plausible pathogenesis. A close liaison with treating physician is very important to define treatment goals. Therapeutic apheresis is a definitive treatment and it should not be used as a last resort when other modalities have failed. So this is a schematic diagram of an apheresis procedure. So in this, as you can see, this is the access line. So we call it as the inlet line. So whole blood is taken from the patient by this access line, which is sent to a cell separator. The cell separator separates various layers of blood, namely plasma as the supernatant, platelets in the middle and buffy coat in the middle, and red cells at the bottom. Whatever the component of interest is separated. It can be collected or it can be removed. The remaining components are mixed with the appropriate replacement fluid, which may be albumin, colloid, fresh frozen plasma, and this is returned back to the patient by the return line. Coming to conventional therapeutic apheresis modalities, these can be divided into 2 broad categories. The first is plasmapheresis and the second is cytapheresis. Now, when the substance of interest lies in the plasma and there has to be plasma removal or exchange, this process is known as plasmapheresis. On the other hand, if the substance of interest is a cellular component, the procedure to remove it or replace it is known as cytapheresis. The subdivisions are erythrocytopheresis, thrombocytopheresis, and leukapheresis for red cells, platelets, and WBCs respectively. So the American Society for Apheresis 2019 defines therapeutic plasma exchange as a procedure in which blood is passed extracorporeally through an automated cell separator which separates plasma. The plasma is removed and replaced with a replacement solution, which could be a crystalloid or a colloid. An example of a therapeutic plasma exchange procedure can be the removal of anti-acetylcholine receptor antibody in patients of myasthenia gravis. On the other hand, cytapheresis is a procedure in which blood is passed extracorporeally through an automated cell separator which separates the cellular components. This collects the target cells and returns the remainder. An example of this procedure is removal of leukocytes that cause leukostasis in patients of leukemia. So what is the rationale behind doing these procedures? For a therapeutic plasma exchange therapy to be effective, the substance in question which is to be removed should exist in plasma, which contributes to a symptom or disease. It should be large enough that it can't be removed by dialysis. It should have a prolonged half-life, and it should be acutely toxic and or it is resistant to conventional therapy. Cytapheresis, on the other hand, is used to lower abnormally high cell counts, erythrocytopheresis to lower red cells, leukocytopheresis to lower WBCs, and thrombocytopheresis to lower abnormally high platelets. So this is a model of interaction between the intra and extravascular compartments and the effect of plasma exchange. Now this part that is circled here is what happens in the intra and extravascular compartment of a patient. The substance to be removed can be in the intravascular compartment, but its concentration is maintained in the extravascular compartment in equilibrium by a process known as diffusion. So when we target the intravascular compartment and do a plasma exchange, the concentration of the substance falls rapidly. But over a period of time, the concentration of the substance in the intravascular compartment starts rising gradually because of diffusion from the substance that was present in the extravascular compartment. And this is the reason why we need multiple cycles of plasmapheresis for an effective therapy. So there are three plasmapheresis modalities that I've described in the further slides. The first is a conventional therapeutic plasma exchange. Second is plasma adsorption. And the third is double filtration plasmapheresis. So till now, the circuit diagram that I had described previously was of a conventional therapeutic plasma exchange, in which the whole blood is taken from the patient. It is mixed with an anticoagulant, usually citrate. It is subjected to centrifugation and separation of components. After that, the plasma is taken into a waste bag. The rest of the components are mixed with an appropriate replacement fluid, and this is returned back to the patient by the return line. Now, since we use citrate as an anticoagulant, there is a risk of hypocalcemia as citrate binds to ionized calcium. So in this procedure, we supplement calcium gluconate to the patient in the return line. Coming to the next modality, this is immune adsorption. Now in immune adsorption, it has adsorptive columns. Now this columns has beads or membranes, and it has the capacity to remove immune globulins by binding them to select ligands on the biochemical surface. Now, one advantage of immune adsorption over conventional plasma exchange therapy is that since the plasma is not being removed and it is only being treated in the column, not much of a plasma replacement solution, replacement fluid solution is required. So there is a lesser chance of allergic reactions. Now here in the schematic diagram, we can see that the immune adsorption column has the myasthenia gravis autoantibodies. The patient's plasma, which consists of the offending antibodies, gets passed through this absorbent column. The beads adsorb the offending antibodies, that is myasthenia gravis, and the antibody-free plasma is then returned back to the patient. Here is the real-time picture, and this is what an adsorbent column looks like. Coming to the third modality, which is double filtration plasmapheresis, it is also known as cascade plasmapheresis. Why so? Because the plasma is being subjected to two filtration processes. Now, this is a comparison of conventional therapeutic plasma exchange with double filtration plasmapheresis. So what happens in double filtration is that first, there is a plasma separator. So in the cell separator, the plasma gets separated as a supernatant. Now, this separated plasma is then again subject to plasma filtration. This filter, the secondary plasma filter, divides the plasma into large molecular containing plasma and small molecule containing plasma. Usually, the pathogenic substances are large molecules, which then get removed. So this is a very small fraction of plasma being removed, and the healthy plasma, along with the appropriate replacement component, are returned back to the patient. In this machine, we can see that this is the centrifugation chamber. So this is where the first separation happens, where the first layer of plasma gets separated, which is then subject to filtration in this column. So after treatment of plasma by this column, the antibody-free plasma is then returned back to the patient. So there are two filtration processes happening here. Now, the therapeutic apheresis equipments are based on two primary principles. They can be centrifugation based or membrane based. In centrifugation based, the plasma extraction ratio is much higher, around 85%. It's a high flow circuit and the anticoagulant of choice is citrate. Whereas in membrane based, the plasma extraction ratio is in the range of 30 to 35%. It is a high flow circuit and the anticoagulant of use is heparin. Now, one problem with heparin is that it causes systemic anticoagulation, and in patients with an already deranged coagulation profile, the systemic effects of heparin may need to be reverted back. So here I have shown a cross section of the centrifugation belt. A whole blood is taken from the patient. It is subjected to centrifugation, and this is how the layers are separated. The innermost layer is plasma, after that platelets and white cells, and after that red cells. So development of all these layers gives us the advantage of selective separation of the component of interest. After separation, the blood is mixed with the appropriate replacement and then returned back to the patient or discarded. Now, the various therapeutic apheresis equipments that we use are shown below. One is Fresenius check, next is Harmonic MCS, and the last is Optia by Thermo. The advantage of these equipments are that they can be used for therapeutic procedures as well as to selectively separate components from healthy donors. These are the kits that we use. So these are one-time use disposable kits. They contain of a cassette, an inlet and return line, and a remove or waste bag. And this is the centrifugation belt that we had seen earlier. Now, in our department, when we do a therapeutic apheresis procedure, we have a format for the procedure monitoring. It consists of 4 parts. The first is an informed consent. Second contains procedure details, which has the patient details, the details of the machine and the kit that we use, and the replacement components. The third part is for the pre and post lab parameters and any adverse events that we have encountered during the procedure. And the last is patient vital monitoring. So if you have to order therapeutic exchange apheresis procedure, we can do so on the HIS system. In the CPOE ordering, we can go to the Department of Transfusion Medicine, and the procedure is by the name of Therapeutic Exchange Apheresis. So how would we go about planning a therapeutic apheresis procedure? So when we receive a consultation for a therapeutic apheresis, we first find out what the indication for the apheresis procedure is. Then we see if there is a rationale in doing the procedure or not. After that, there is patient assessment. So we assess for the lab parameters of the patient, a venous access, what would the appropriate replacement fluid be, the total body volume, total blood volume estimation, and the amount of whole blood that will be processed for the apheresis procedure. Depending on that, we plan the number of procedures and the frequency with which we have to perform the apheresis procedures. During the procedure, there is intra-procedure monitoring of patient vitals and ionized calcium for the effects of citrate on calcium and to prevent hypocalcemia. When to stop therapeutic apheresis is when we get an appropriate clinical response or there is betterment in the lab parameters. An important point to note here is that all medications should preferably be given after therapeutic apheresis. Dose adjustment should be considered because drugs are also removed depending on the drug and patient pharmacodynamics. So the American Society for Apheresis 2019 divides the therapeutic apheresis procedures into 4 categories. Category 1, therapeutic apheresis is the primary therapy or it is a valuable first-line adjunct. An example of this is myasthenia gravis or thrombotic thrombocytopenic purpura. Category 2, where it is a supportive or adjunctive treatment, to more definitive treatments. An example of this is multiple sclerosis. Category 3, when the existing evidence is insufficient either to establish the efficacy or to clarify the risk to benefit ratio. An example is lupus. And category 4 is when therapeutic apheresis procedures show no benefit in control trials or anecdotal reports have been discouraging. An example is polymyositis. So for the last 5 years, we have performed various therapeutic apheresis procedures in the department. So this is a graph diagram showing the number of procedures that we have performed in the corresponding year. So in 2017, we were doing around 117 procedures in 1 year. In 2020, we had a dip because of the pandemic, but this number is steadily increasing, and we hope to do many more procedures at our institute. The rest of the presentation, Dr. Pallavi would carry forward.
Thank you, Dr. Kriti. A very good morning to all. I'll be sharing our experience with therapeutic apheresis in the last 5 years. Therapeutic apheresis was performed on 142 patients, and the patient age group ranged from 8 to 68 years. A total of 719 procedures were performed, out of which 703 were plasma exchange procedures and 16 were therapeutic cytapheresis procedures. The number of procedures per patient ranged from 5 to 17 for the therapeutic plasma exchange and 2 to 4 for therapeutic cytapheresis. We also performed procedures on pediatric patients. A total of 17 procedures were performed on 5 patients, and the indications for this pediatric patient range from Wilson's disease and post-liver transplant patient undergoing acute liver failure. For Wilson disease, which is a category 1 indication, we had 4 patients, and for post-liver transplant, which is a category 1 indication, again, we had 1 patient. In pediatric patient, an additional point which has to be considered is of RBC priming, which is necessary as these patients have small total blood volume. Now, this table represents the department-wise indications for which we are performing the therapeutic apheresis. This list is of therapeutic plasma exchanges done in various departments, and the maximum number of procedures were done for myasthenia gravis and acute liver failure, and both of these are category 1 indications. This list is of department-wise indication for therapeutic cytapheresis. We performed 1 procedure for red cell exchange. The indication was for which was sickle cell disease. 7 thrombocytopheresis procedures were performed for the indication of reactive thrombocytosis, and 8 leukocytopheresis procedures were performed for the indication of leukostasis syndrome. For performing therapeutic cytapheresis, the major indication belongs to the category 2. Now, this image shows the bar graph representation of total numbers of procedures performed in various departments. The x-axis shows various departments clustered as neuromedicine, critical care medicine, hematology, and miscellaneous. Among miscellaneous department, the major procedures were performed for pediatric gastro, MRH, and the y-axis is representing the number of procedures performed. So the blue graph represents the category 1 indications for each department. The red graph shows the category 2 indication. The green graph bar is showing the category 3 indication procedures, and the purple is showing the category 4 indications for the various departments. Also from this, we can see that the major procedures belong to the category 1 and 2. For the therapeutic plasma exchange, the total number of patients treated were 135, for whom 703 procedures were performed. For category 1, we have 52 patients. 57 patients belong to the category 2 indication. 24 patients belong to the category 3, and 2 patients belong to the category 4 indication. A favorable outcome was observed in 116 patients out of 135, which accounts to 86% of the patient. An unfavorable outcome was observed in 19 patients, This was mainly because we cannot perform the complete therapeutic plan in such patients because of their deteriorating clinical conditions, or even we lost such patients. For cytapheresis, total number of patients treated was 7, on whom 16 procedures were performed. One procedure was for red cell exchange. Two patients were taken up for WBC depletion, and 4 patients were taken up for platelet depletion. And a favorable outcome for cytapheresis was obtained in all the 7 patients. So here the outcome was 100%. Again, out of these 7 patients, 6 patients belong to the category 2 indication and 1 patient belonged to the category 3 indication. There are several adverse effects also associated with these therapeutic apheresis procedures. We have observed total of 105 reactions during out of 719 procedure, which accounts to a reaction percent of 14%. Most of these reactions were mild allergic type, accounting to 9.3% procedures. These allergic reactions were in the form of rashes, urticaria, and was well managed by the use of antihistaminics and steroid. The next reaction which we observed was hypertension, which occurred in around 4.3% of the procedures, and this hypertension was more commonly observed in the patients who were under myasthenic crisis, and this was as much as 50% of the myasthenic crisis patient. Only 0.9 hypocalcemic reactions were reported in all the procedures. Now we'll be taking up some clinical cases. These clinical cases are to represent the patient response by therapeutic plasma exchange and therapeutic cytapheresis. The first case is of a patient of fulminant Wilson's disease. A 10-year-old male patient was diagnosed as acute and chronic liver failure due to Wilson's disease, presented to our institute with the history of jaundice for 2 months, ascites for 2 months, and cola-colored urine for last 15 days. Here the rationale for performing the therapeutic plasma exchange was as this procedure has acted as an adjunct therapy or a bridging therapy for liver transplantation. So we get sufficient time so that patient gets planned up or taken for the transplant. And also the procedure, the plasma exchange tends to improve the deranged liver function in such patients. So this was a category 1 indication for performing the plasma exchange. We planned the procedure for 5 sessions. The first 3 procedures were done daily, and then the remaining 2 procedures were done on the alternate days. In the adjoining image, we can see that the color of the removed plasma is so dark because of the hyperbilirubin which was existing in this patient. Now, few points regarding the Wilson's disease. It is an autosomal recessive disease which leads to the mutation of the ATP7B gene, which encodes an ATPase protein. Now, because of this gene mutation, there is impaired biliary copper excretion. So now the copper gets accumulated in the liver, brain, cornea, and the kidney, and leads to these organ failures. This manifests as increased 24-hour urinary copper and elevated serum copper levels in the patient. Therapeutic plasma exchange proves to be an adjunctive therapy to remove the copper and stabilize the coagulopathy and anemia which exist in such patients. This table is showing the comparison of hematological and biochemical parameters before and after completion of 5 sessions of plasmapheresis in Wilson disease patient. So there was a drastic change in the urinary copper levels, serum copper levels, bilirubin levels, and PT-INR. This image shows the graphical representation and the trend of change of these biochemical parameters with our plasma exchange sessions. The blue line is depicting the serum copper levels. As we can see, the baseline level was 254, and after the completion of 5 cycles, it is improved to a level of 75. The red line depicts the trend of the total bilirubin. To begin with, the bilirubin levels were 25.9 and has further improved after 5 sessions to 4. The PT before beginning the procedures was 71 and has improved to 27.3. For this patient, we had also performed a baseline, and after the baseline tag and after completion of all the sessions, again a tag was done. So the figure A is representing a baseline tag, and as we can see, this tracing is showing an hypercoagulable state, means the coagulation was deranged, and also a secondary fibrinolysis was existing in this patient. After the completion of all the 5 sessions, again a tag tracing was done, and we can see a normal coagulable state was achieved without any fibrinolysis. Now for the assessment of liver failure, we have certain scores, namely New Wilson scores, MELD score, Child-Pugh score, and Cliff-Sofa scores. For assessment of liver failure patients, the Cliff-Sofa scores is considered to be the best, but in Wilson disease patient, New Wilson scores is considered best. A cutoff score of 11 predicts 83% mortality at 28 days without transplantation. And in this patient, these scores were assessed pre-procedure, after the first procedure, after third procedure, and after the fifth procedure. So, looking at the New Wilson index, you can see the pre-procedure index was 16, and after the completion of all sessions of plasma exchange, that has improved to a score of 8. In this patient, urine hemoglobin also reduced to 1+, which was earlier of the grade 4+. The patient was later referred for liver transplantation and has not recovered well. So in this case, we have seen that TP has proved to be an effective adjunct therapy for the liver transplant. With each session, the liver profile of the patient has improved, and after the complete session, the disease severity score has also improved, thereby improving the 28-day survival of this patient. The second case is of osmotic demyelination syndrome, which is a very rare entity. This patient was a 38-year-old female, a known case of polycystic kidney disease for last 14 years and hypertensive for last 9 years. This patient presented with history of severe hyponatremia, and the sodium levels were 107 with existing metabolic acidosis. 19 days back, the patient had vomiting, diarrhea, and also, as the patient was on diuretics, was the only cause which, and all these 3 causes led to the development of hyponatremia in this patient. For hyponatremia, sodium correction was done, and after 8 hours of the correction, her sodium levels were 123. The next day, patient developed generalized tonic-clonic seizures and was later started on phenytoin and valproate. With use of phenytoin and valproate, even though the seizures settled, but the patient's sensorium didn't improve. The tone was decreased in all the 4 limbs with no response for deep tendon reflexes and plantar reflex. The Apache score was assessed as 24 for this patient. Subsequently, the patient was intubated. On electroencephalogram, atypical triphasic waves suggested of metabolic encephalopathy, and on MRI, a pontine and extrapontine myelinolysis was confirmed. Most probable cause for this myelinolysis was supposed to be neuronal damage, which might have occurred following abrupt fluctuations in the osmolality that occurred during the rapid correction of the existing hyponatremia. So this is the image which represents the pathophysiology which underlies the osmotic demyelination syndrome. So normally the neurons maintain their shape when the serum osmolality is normal. Whenever hyponatremia occurs, the neurons transiently solve and adapt to this chronic hyponatremia. Rapid correction of this hyponatremia leads to rapid water efflux from the neurons and leads to their shrinkage and apoptosis. This leads to the this shrinkage leads to the disruption of the blood-brain barrier. So now the glial cells are exposed to the circulating cytokines and complements which are toxic for the blood-brain barrier as well as for the neurons. So again, the ATP depletion and apoptosis will lead to the demyelination, and this is the cause for the demyelination which is occurring in osmotic demyelination syndrome. This osmotic demyelination syndrome manifests as dysarthria, dysphagia, behavioral disturbances, lethargy, confusion, and coma. There are multiple case reports which showed complete or partial recovery after various treatment strategies, namely relowering the sodium, use of desmopressin, use of therapeutic plasma exchanges, and immunoglobulins. For this patient, therapeutic plasma exchange began on day 19th from the development of symptom, and this corresponded to the day 12 at SGPGI. The rationale for performing therapeutic plasma exchange was to lower the levels of these myelotoxic cytokines. This is in category 3 indication, and we plan total 6 procedures for this patient on alternate days. Now this graph is showing the sequential sodium values for this patient. The baseline sodium value was 107, for which rapid correction was done, and now the sodium value was 123. On admission at SGPGI, the patient presented with neurological symptoms pertaining to the ODS, and now the serum sodium levels were 134. After which we started the plasma exchanges. Now the patient was also intubated at this stage, and normal sodium levels were obtained. So here we can see that therapeutic plasma exchange has again helped in gradually weaning the patient. This patient was laterally discharged and weaned off the ventilator with the GCS score of E2, V3 and M2. And here the plasma exchange has proved to be effective in weaning of the patient and also in the recovery after the deteriorating condition. The third case is of a Marburg's variant of multiple sclerosis. It is again a very rare entity. Multiple sclerosis is a chronic disease, but Marburg's variant is more fulminant form of this multiple sclerosis. A 32-year female who was diagnosed as multiple sclerosis Marburg's variant presented to our institute with complaints of loss of vision for 28 days, inability to walk with both limbs for 20 days, inability to use upper limbs for last 10 days, sensory loss in all 4 limbs for last 10 days, and difficulty in breathing for last 5 days. There was no family history of any such disease or other neurological disease in this patient. The image shows an MRI of this patient where the bilateral optic nerve involvement was there, which led to the vision loss in this patient. A few words about the multiple sclerosis. The humoral as well as the cell-mediated immunity, along with the genetic and environmental factors, are responsible for the focal areas of demyelination in the white matter. And this multiple sclerosis is considered irreversible. It manifests as monoocular visual loss due to involvement of the optic nerve, limb weakness due to transverse myelitis, double vision due to involvement of the brainstem, and ataxia due to the cerebellar lesions. Here, the rationale for performing plasma exchanges was that there are very few case reports for this variant of multiple sclerosis with no definitive treatment. So, as this was a fulminant form, therapeutic plasma exchange here helped by the immediate removal of antibodies and the immune complexes, which were leading to these demyelination. Also, with each plasma exchanges, there occurred a redistribution from the tissue to the vascular space, which further led to the improvement of the patient's symptom. This patient was a category 2 indication for performing the plasma exchange. Our treatment plan constituted of 13 procedures. The first 6 procedures were done on alternate days. The 7 to 10 procedures were done twice weekly, and 11 to 13 procedures were done weekly. This table demonstrates the various hematological and biochemical parameters of the patient with each session, and as we can see, all the parameters were stable throughout all procedures. Just after the second therapeutic plasma exchange procedure, patient respiration improved and now breathing was with minimal efforts. Just after the 7th procedure, patient developed perception of light in both the eyes. Patient was discharged in a stable condition with perception of hand movements in both eyes, reversion of sensory loss in forelimbs, and with minimal reversion of the motor loss. So again, in this case, TPE has proved to be an effective treatment by immediately removing the antibodies and the immune complexes which were leading to the demyelination, and has helped in the recovery of patient vision, respiration, and reversal of the sensory loss. The fourth case which we are going to discuss is of a myasthenia gravis patient, a 58-year female who was a known case of type 3 thymoma post radiotherapy, was admitted for thymectomy. Therapeutic plasma exchange began on post-operative day 11 of thymectomy in ICU in consideration of prolonged ICU stay of this patient and inability to maintain oxygen saturation despite being on BiPAP, for which patient was further planned for intubation. This patient was already on immunosuppressants and choline esterase inhibitors, so further there was no treatment left which can be performed in this or administered in this patient. The myasthenia gravis is an autoimmune disease in which antibodies are formed against the acetylcholine receptors and the muscle specific kinases. These antibodies block the neuromuscular junction. So with the use of therapeutic plasma exchange, we are trying to manage the acute myasthenic crisis state post-surgery by rapid removal of these antibodies. And myasthenia crisis is again a category 1 indication for performing the therapeutic plasma exchange. For this patient, we performed total 7 procedures and they were done on alternate days. The hematological and biochemical parameters with all the 7 procedures showed that they were stable throughout and no adverse effect was reported in this patient. Just after the first procedure, the patient didn't require the need for intubation and also the BiPAP was removed. Now the patient was put on to face mask with the oxygen requirement at 10 liters per minute. Just after the third procedure, the oxygen requirement reduced to 2 liters and now the patient was ambulatory, able to take oral feed. And just after the 6th procedure, patient was stable, shifted from ICU to the ward and discharged after the 7th procedure. Here an additional point regarding the myasthenic crisis patient which we would like to discuss is that we have observed severe hypertensive reaction during the plasma exchanges in post-thymectomy myasthenic crisis patient. And this rate is this hypertensive reaction occurs in around 50% of these myasthenic crisis patients. So it is recommended to perform a minimum of 2 procedures pre-operatively for such patients. And these guidelines are also suggested by the American and European societies, and they recommend the plasma exchange in preparation for thymectomy. So All these 4 cases have shown that how therapeutic plasma exchange have proved in recovery or getting a back patient from the acute or serious conditions to a better dischargeable condition or in a stable state. Now I would like to invite Dr. Kriti again for discussing further.
Thank you, ma'am. The last 4 cases, we have seen how therapeutic plasma exchange has proven to be a beneficial modality of treatment. This last case is slightly different as we are using therapeutic cytapheresis in this case. So we have a case of a 33-year-old male who was diagnosed with mellidosis, which is also known as Whitmore's disease. This is caused by a gram-negative bacillus, Burkholderia species, and this patient had bilateral septic arthritis of knee, splenic infarct, liver abscess, and reactive thrombocytosis, that is elevated platelet count. So this patient's rising platelet count reached a maximum of 14 lakhs per microliter. So the rationale of performing a cytapheresis was for immediate reduction of platelet counts to prevent thrombosis. Thrombocytopheresis as a procedure is performed when the platelet count exceeds 10 lakh per microliter. So a little bit about reactive thrombosis. It is a condition when there is abnormally high platelet count in absence of chronic myeloproliferative disorders. This can be secondary to infection, inflammation, or hemorrhage. Mellidosis, a key point to note here in mellidosis is that we often encounter thrombocytopenia, that is low platelets, and this feature of thrombocytopenia is correlated with the mortality of the patient. But paradoxically, in the current patient, thrombocytosis was present secondary to infection. So this is a graph that shows the trend of the platelet count of the patient. On day 3 of admission, the platelet count was 3.9 lakhs. It was steadily rising, and on day 7, it went to 10.3 lakh. A consultation was sent to us on day 9 when the counts were 12.9, and we took a decision to perform a therapeutic thrombocytopheresis. So we performed the first procedure when the platelet count of the patient was 14 lakhs, and after the first procedure, the platelet count drastically dropped down to 7.6 lakhs. After that, we had a gap of 2 days when we noticed that the platelet count had started to rise again. So we took a decision to perform a second cytapheresis procedure, after which the counts dropped to 4.3 lakhs. Post second procedure, the counts steadily were dropping, and by day 20, they had reached a level of 3.4 lakhs. So after 2 procedures, the patient was able to maintain the platelet count in the range of 3.5 to 5, which was satisfactory. So in this case, therapeutic cytapheresis was able to lower the platelet count and thereby reduced the thrombosis and its related complications. So we have presented a total of 5 cases, 4 with therapeutic plasma exchange as the treatment modality, and 1 case of cytapheresis. And so we have some take-home messages from this presentation. First is that therapeutic apheresis works as a tool for immune modulation. It has changed the entire spectrum of immune complex disorders in treatment and rehabilitation of so-called incurable diseases. It has resulted in a better quality of life by lowering morbidity and mortality. And the keys for an effective apheresis procedure are coordination with the physician and choosing the right indications. To conclude, the Department of Transfusion Medicine can also extend its services as the department is equipped with facilities which are addendums of therapeutic plasma exchange. So we can perform various procedures in desensitization in ABO incompatible bone marrow transplants or solid organ, that is liver or kidney transplant. It is effective bridging therapy in liver failure in patients who are awaiting liver transplant. We have use of adsorption columns which are specific for specific diseases like familial hypercholesterolemia, sepsis, SLE, and hypobilirubinemia. We also have extracorporeal photopheresis for the management of graft versus host disease. And we're also taking up cases of cytokine storm, conditions that have cytokine storm, like for the treatment of sepsis, or we see that in COVID-19 patients or patients with multiple organ dysfunction syndrome. So thank you so much. We would like to thank the Department of Critical Care, Endosurgery, Hematology, Neurology, and Pediatric Gastrology, especially to help us in having a successful plan of development.